Okay, it's now 25 minutes after the hour. We are returning from break and we have a series of presentations this afternoon. We are going to start with an update to clinical considerations by Dr. Hall from CDC. As a reminder, we only vote on recommendations, but for the clinical considerations, which are often nuanced and respond to much of the feedback that comes through when implementation occurs, that this is meant for discussion. So please provide feedback and discussion around the clinical considerations. And I'll turn it over to the room at CDC to get us started.
All right, thank you. I'm Alicia Hall, and today I'll be covering anticipated updates to the interim clinical considerations for use of COVID-19 vaccines. Next slide, please. So anticipated updates will include clarification and updates on guidance for people who are moderately or severely immunocompromised, updates to recommendations on passive antibody products, and reduction and reorganization for ease of use. Next slide, please. I'll start with updated guidance for people who are moderately or severely immunocompromised. All guidance in this section will apply only to this population. Next slide. As a reminder, recommendations for people who are immunocompromised at the time of vaccination are already different than recommendations for most people. This is because this group is at increased risk for severe COVID-19 and more likely to have serious breakthrough infections. They may not mount a protective immune response after a 2-dose primary series and in general have lower vaccine effectiveness than people who are not immunocompromised and have waning protection over time. Next slide. Before I dive into changes, here is the current COVID-19 vaccination schedule for people who are moderately or severely immunocompromised. Similar to the recommendation for the general population, mRNA COVID-19 vaccines are preferred for all doses over Janssen COVID-19 vaccine. For those in this population who choose an mRNA COVID-19 vaccine primary series, this includes a 2-dose primary series, 1 additional dose. This is not indicated for people who are immunocompetent, and 1 booster dose for people ages 12 years and older, for a total of 4 doses. For those who choose Janssen, this includes 1 primary dose and 1 booster dose. Next slide, please. There has been recent confusion about the recommendations for this population, including reports of people who choose mRNA COVID-19 vaccines being denied their 4th dose. In addition to communication efforts, we are adding more clarification in the clinical considerations to emphasize this population should receive 3 doses for a primary series and 1 booster dose if they are ages 12 years and older for that booster dose. There are no changes in the number of doses here. It is simply clarification to address these challenges we are hearing. Next slide. The next few changes I'm going to discuss are possible through use of emergency use instructions, or EUI. EUI are allowed under the Pandemic and All Hazards Preparedness Reauthorization Act. EUI provide information about emergency use of FDA-approved medical products that may not be included or differ from the information provided in the FDA-approved labeling package insert. Since EUI are only for FDA-approved products, this only applies to the 2 approved COVID-19 vaccines, which are Spikevax or Moderna, for which guidance would apply to people 18 years and older, and Concurrent or Pfizer BioNTech, for which guidance would apply to people 12 years and older. Next slide. EUI materials, including fact sheets for healthcare providers, fact sheets for recipients and caregivers, and FAQs can be found on the website listed on this slide. Next slide. Revisions utilizing the EUI mechanism for people who are moderately or severely immunocompromised include a shorter booster interval after an mRNA COVID-19 vaccine primary series, an additional dose after a Janssen COVID-19 vaccine primary series, and case-by-case clinical decision-making. Next slide. Currently, people who are moderately or severely immunocompromised who received an mRNA COVID-19 vaccine primary series are recommended to receive a booster dose at least 5 months after completion of the series. This 5-month booster interval will be revised to at least 3 months after completion of the mRNA primary series. Next slide. The rationale for this decision was out of an abundance of caution to help this population that may not be as well protected get their booster dose sooner, particularly with concerns about initial immune response, loss of protection over time, and high community transmission due to the Omicron variant. To support this change, small studies demonstrate immunogenicity of a 4th dose when administered 1 to 3 months after the 3rd dose. Among participants with seronegative or low positive responses after 3 doses, 42 to 66% were seropositive after 4 doses. Additionally, multiple studies demonstrate immunogenicity of a booster dose as early as 3 months in the general population following a 2-dose primary series. And finally, multiple countries have implemented booster doses as early as 3 months in the general population following a 2-dose primary series. Next slide. Next, guidance will be added on the schedule for people who are moderately or severely immunocompromised and who received a Janssen COVID-19 vaccine primary series. These people are currently recommended to receive 1 booster dose at least 2 months after completion of the primary dose. An mRNA COVID-19 vaccine is preferred for the booster dose, but Janssen COVID-19 vaccine can be used provided the patient is educated on the risks and symptoms of thrombosis with thrombocytopenia syndrome, the need to seek medical care should such symptoms develop, and the availability of mRNA COVID-19 vaccines. Next slide. The revised guidance will add an additional dose to this schedule. So, people who are moderately or severely immunocompromised would be recommended to receive 1 additional dose at least 28 days after the primary Janssen COVID-19 vaccine dose, and 1 booster dose at least 2 months after completion of the additional dose, for a total of 3 doses. We realize many people may have already received 2 doses, their primary dose and booster dose. Our guidance will address what to do if someone has already received a booster dose. There is not guidance for more than 3 doses. Next slide. Finally, we'll be adding language that, on a case-by-case basis, providers who care for moderately or severely immunocompromised patients may administer mRNA COVID-19 vaccines outside of the FDA and CDC dosing intervals based on clinical judgment, when the benefits of vaccination with a different schedule or dosage are deemed to outweigh the potential and unknown risks. However, providers should not routinely administer additional doses of COVID-19 vaccine beyond those recommended in this guidance. Additionally, I'll note antibody testing is not currently recommended to assess the need for vaccination or assess immunity following vaccination. Next slide. Putting these recommendations together, the revised schedule for people who are moderately or severely immunocompromised is shown on this slide, with differences from the current schedule shown in orange. So, people who receive an mRNA COVID-19 vaccine primary series should receive 3 primary doses followed by a booster dose 3 months after completion of the primary series. The 3-month interval is the only change here. People who receive a Janssen COVID-19 vaccine primary series should receive an additional dose 28 days after the primary series, followed by a booster dose 2 months after the additional dose. Both the additional dose and the interval has changed here. Finally, I'll move on to passive antibody products, which applies to everyone, not just those who are immunocompromised. Next slide. Currently, for people who have received passive antibody products for COVID-19, there's a recommended deferral period before vaccination. People should defer vaccination for 30 days if the product was used for post-exposure prophylaxis and 90 days if it was used for treatment. With our revised guidance, people who previously received antibody products had a little freeze there. With our revised guidance, people who previously received antibody products, for instance, anti-SARS-CoV-2 monoclonal antibodies or convalescent plasma, as part of COVID-19 treatment, post-exposure prophylaxis, or pre-exposure prophylaxis can be vaccinated at any time. There is no longer a recommended deferral period for COVID-19 vaccination following receipt of an anti-SARS-CoV-2 antibody product. I will mention here, though, in people who previously received a COVID-19 vaccine, Evusheld for pre-exposure prophylaxis should be deferred for at least 2 weeks after vaccination, per the product EUA. Next slide. The reason for removing the deferral period is based on a balance of benefits and risks. First, a study among nursing home residents and staff demonstrated that recipients of the monoclonal antibody bamlanivimab mounted a robust immune response to mRNA vaccination, regardless of age, risk category, or vaccine type, suggesting an interval dose does not need to be tailored to particular subgroups. Although antibody response was numerically lower in people who received monoclonal antibodies, it was still considered to be high, and the clinical significance of the reduction is unknown. Most notably, there was no correlation between interval to COVID-19 vaccination and neutralizing titers. Programmatically, there can be challenges to current intervals between receipt of monoclonal antibodies and COVID-19 vaccination, which may reduce the likelihood of getting vaccinated. And finally, in the current setting of the COVID-19 pandemic, getting people vaccinated, including booster vaccination, is a priority, and the benefits likely outweigh any potential risks for immune interference from monoclonal antibodies. Next slide. Finally, we're in the process of streamlining the content and layout of the interim clinical considerations for increased usability. You can find our interim clinical considerations on the website shown on the slide, and they may look a little different the next time you go there with this streamlining of content. Next slide. And I failed to make an acknowledgement slide, but I do just want to thank our CMO and clinical guidelines and clinical education group for being critical in putting this guidance together. Thank you.
Thank you so much, Dr. Hall. And I have to say, these changes are very much welcome for those of us who are providing care or recommendations on the front line. So this is really helpful, practical implementation information that I think will make a huge difference to many of the patients we care for. I'm going to ask if there are any questions or discussions people want to raise as part of these clinical considerations that are being proposed. Dr. Cotton.
I'd just like to second what you said, Dr. Lee, that this is a really, really important update for immunocompromised patients. In the past 2 months, I've seen many of these immunocompromised patients who had followed all the rules still have significant breakthrough infections, and I really think that this will help dramatically. So thank you very much for these important updates, and also on the passive antibody, because as many of us are rolling these out, clarity there is going to be really, really helpful. So greatly appreciative.
Thank you, Dr. Cotton. Dr. Brooks?
Yes, and again, excellent presentation, and glad to see this. I have a question regarding the J&J for immunocompromised. It shows that for the second dose, you should only use an mRNA vaccine, but for the quote-unquote booster, you could use any vaccine. Can you just explain that difference in recommendation?
Yeah, thank you for that question, because it is confusing. So the main reason for this is due to legal limitations. So For the recommendations that have been added for moderately or severely immunocompromised, including this recommendation, they're possible through those emergency use instructions, which can only use licensed vaccines. So the additional dose we've added on must be Pfizer or Moderna because that's all that's allowed through the emergency use instructions. And the booster continues to be preferred for Moderna and Pfizer due to the risk for TTS.
Okay, thank you.
Thank you. Dr. Sanchez.
Yes, I have a similar question about that. So, for the Janssen product, the additional dose, like you said, only Pfizer or Moderna, but then the booster, it could be also the Janssen. And I guess my question is, are the data that strong that it has to be at least 2 months and the other one at least 3 months? And especially if the second dose is a Pfizer Moderna, can't we just harmonize and say that all of them should be given 3 months or later? It'd be nice to just, we're grappling with the 21, 28, 1 month, 2 months. Why not just do both booster doses all at 3 months?
Yeah, I understand what you're saying. It is very confusing to have all of these different intervals. So the 2 month is currently allowed under the EUA for the booster. We had not considered extending that. For the mRNA, we wanted people to get it sooner, but Janssen is already sort of sitting with that 2 month. So we would have to look into what would be possible to actually extend it. And I'm not sure we would necessarily want anyone to get the booster later.
Thank you. Dr. Lear.
Yeah, so we just voted to extend the BLA for the primary series for Moderna. It seems to me that these clinical considerations are going past that and making suggestions that still fall under the EUA. And I guess I just want clarification that it's appropriate to do that. My sense in the past has been the EUA was a strict guideline and that you shouldn't bend those rules at all. And so if we're going past that, is that appropriate? Thank you.
Yeah, thank you for that question. It is kind of confusing because this is through the EUI instead of the EUA. CDC is allowed to issue emergency use instructions that go outside of what is indicated in the package insert. So that is the reason that we're able to do that and it still be covered.
Thank you. Dr. Freihofer?
Thank you. This has been an excellent presentation. My question is about slide 7 and the EUI. Again, a little bit more confusion on my part. So it says applies only to use of Spikevax that's approved for 18 and older and Comirnaty for age 12 and older. I thought that the Comirnaty was only FDA approved with the BLA for 16 and older.
Great question. I was actually waiting for that question because these EUI are super confusing. So you're correct. Comirnaty is 16 and older, licensed for the 2-dose primary series. So essentially, and I will caveat that I am not a legal expert, so I will explain this as best I can. But essentially, the EUI allow for use of approved vaccines. So since Comirnaty is the gray cap and purple cap vials, since those are, as they would be called, BLA compliant vials, anything in the EUI can apply to those vials, and since they can be used for ages 12 years and older, that is why it can apply down to that age. I I hope that explained it. I know it's super confusing.
And this is Sarah and Bay. I wanted to also, I know, emergency use instructions are kind of a new pathway that many people are hearing about for the first time. I just want to make the point that we are using these in close coordination with FDA, and it's through mutual consultation that we have sometimes made the decision that it is more appropriate to use an EUI for certain things versus other regulatory mechanisms. So we're not going outside of the FDA, we're actually collaborating with them to find the best path forward that would legally allow us to make some necessary changes to the clinical considerations.
So this is Sandy Fryhofer again from the American Medical Association. So we can still do this for those as young as age 12, though. That slide is correct then, right?
That is correct. Yeah. So unfortunately, not able to go down to the 5 to 11 age range, but can go down to the 12 years.
Thank you.
Thank you. Are there any other questions, comments, discussion? Okay. Thank you, Dr. Hall, for your presentation. We will move on to our colleagues from the Public Health Agency of Canada, Dr. Tunis, Dr. Warshawski, and Ms. Ogunaki-Cook, who are kindly sharing their Canadian experience with us around COVID-19 vaccine primary series extended intervals. So, Dr. Tunis, I'm going to turn it over to you.
Thanks so much. Can you hear me okay?
We can, thank you.
Excellent. Thank you for the opportunity to come present here today. So if you can go to the next slide, just for a brief overview, we're going to talk about the Canadian program context. We'll go through some highlights of evidence that have informed the Canadian recommendations, thinking about the one-dose effectiveness during the duration between doses. We'll look at the immunogenicity with longer intervals, the effectiveness with the longer intervals, and then the safety with the longer intervals as well, which is some emerging data. Next slide, please. So Canada's National Advisory Committee on Immunization, or NACI, has been providing advice on the COVID-19 vaccine intervals since 2020. And I think it's important to note a bit of a structural difference throughout the pandemic between the Canadian and US context. So under the terms of reference, even under a regulatory interim order throughout most of the pandemic, which would be roughly comparable to the EUA in the US, NACI was permitted to issue off-label advice on COVID-19 vaccines as per usual. So there have been a number of off-label recommendations really from day one of the COVID-19 vaccines, and there's been no issue around that. So that's a bit of maybe a structural difference. NACI has provided several updates on extended intervals for the primary series as evidence has evolved. And so here is really just Cole's notes on a sort of a timeline of how things evolved in Canada and with some highlights internationally as well. So from the beginning with the COVID-19 vaccines in December, NACI actually recommended an alternate interval of 28 days for Pfizer, which is of course longer than the 21-day authorized interval. Then early in December, Quebec's Provincial Immunization Committee, which is a provincial committee within Canada, there are strong linkages between NACI and that provincial committee as well. That provincial committee recommended first doses to all priority groups before second doses. Then December 30th, we saw JCVI in the UK recommend 3 to 12 week interval for Pfizer BioNTech and a 4 to 12 week interval for AstraZeneca to maximize first dose to priority groups. Then an alternate interval was recommended by NACI in January, moving out to 6 weeks or 42 days based on the clinical trial data and the efficacy estimates that did include up to 42 days. So that alternate interval, preferably within 42 days, would be to maximize first doses to priority groups. Then the big shift in Canada happened really in March when NACI recommended up to a 4-month interval for all COVID-19 vaccines. And there was a full statement with all of the evidence and rationale in April. And then in the fall, that interval was refined further to 8 weeks. So NACI recommended an optimal interval of 8 weeks for adolescents and adults. When the pediatric 5 to 11 program came through in Canada, NACI recommended at least 8 weeks for that in November. And then I've just noted that on January 21st, WHO and SAGE recommended a 4 to 8 week, or preferentially 8 week interval as well. Next slide, please. So as you can see, it's been an evolving story in Canada around intervals. The settling place does seem to be around 8 weeks. The core principles that have informed NACI interval recommendations have been fairly diverse. So the extended interval recommendation up to 16 week that was back in March of 2021 was informed by initially a trigger for limited supply. There was early vaccine effectiveness assessment of strong one-dose protection from mRNA clinical trials and also from Israel, and later from Canada and UK research and surveillance. AstraZeneca 2-dose clinical trial, which did show that longer intervals yield better vaccine efficacy. There was modeling to optimize program impact in the context of limited supply, and of course, immunology and vaccinology principles, and ethics, equity, feasibility, and acceptability. And the subsequent move in the fall towards an 8-week interval was additionally informed by Canadian and UK vaccine effectiveness data, demonstrating increased protection with those longer intervals, which plateaued around 8 weeks. Then the immunological data on the breadth and duration of immune response with longer interval, Canadian safety surveillance showing lower rates of myocarditis with a longer interval, which you're going to hear about later in the presentation, and ethics, equity, feasibility, and acceptability again. So just to note that while the safety and myocarditis has been an emerging part of the story now, it actually is a latecomer to the Canadian interval story, that originally it was driven more by other vaccine principles, and now the safety and myocarditis rates have also additionally augmented and informed that. Next slide, please. So just to briefly recap on some immunological principles around the longer intervals, we know that affinity maturation can be improved, and the longer interval between primary and secondary antigen exposures will allow immune memory cells more cycles of affinity maturation to develop higher affinity, and this may increase the breadth and or neutralizing activity of the response. There's less potential for immune interference also with longer intervals, so the circulating antibodies may interfere with immune responses of the subsequent exposures because of epitope masking, where the circulating antibodies can occupy antigen binding sites, and also reduced antigen availability, where antibodies can actually form immune complexes and be cleared out if the antigen is reintroduced too soon. Next slide, please. So I'll hand it over now to Dr. Warshawski to go through some of the evidence on the effectiveness, immunogenicity, what we've seen, and then also the emerging safety. Thanks.
Thanks very much, Dr. Tunis, and just confirming that you can hear me?
Yeah.
Great. Thanks for the opportunity to present and to continue the story that Matthew has started. So the first area that we explored when we were looking at our extended interval was the vaccine effectiveness with regard to the one dose. So we had been looking at the literature that was available at the time, and as Matthew mentioned, we published a statement on April 7th that summarized the literature to that point. So based on that summary, one dose of mRNA vaccine was shown to be effective against symptomatic disease and infection at about 60 to 80%. Some of the estimates were a bit lower, some of them were a bit higher, but they were in that range. Now that was a little lower than we had expected based on the one dose efficacy from the clinical trial, which was 92%, and also lower than the effectiveness and efficacy with the 2 doses. But very reassuringly, the one dose protection against serious outcomes was higher than against symptomatic disease and infection at around 80% or more. Next slide, please. So our next question was, how long would the protection from one dose last? And here we relied on information from our colleagues from the UK, which, as Matthew mentioned, had started the extended interval ahead of us. So they presented to us on a regular basis, and this is a summary of the data that they have. Here we're seeing the vaccine effectiveness following the first dose over time. So in the upper left, you can see for the 50 to 64-year-olds who have had one dose of the Pfizer BioNTech vaccine, the vaccine effectiveness is around 60%, but then when you get out to about 8 weeks after that first dose, it decreases a little bit to 40 to 50%. Similarly, in the upper right-hand corner, you can see for the 65 to 79-year-olds, around 60% out to 10 weeks, and then it decreases a little bit after that as well. So on the next slide, so knowing that there is vaccine effectiveness with one dose and that it lasts 8 to 10 weeks, The other thing that we were very interested was, as Matthew mentioned, this principle from immunology that the longer the interval between the first and second dose, you might expect a higher immune response after that second dose. And this was borne out in trials that came out of the UK as well. This is their consensus cohort of 750 people who they followed, who had periodic serological testing. They were 50 years of age and over. And here you can see that based on the interval between their first and second dose, the geometric mean titers that were achieved after the second dose. So you can see here that when the interval is shorter, the geometric mean titers are lower. And then as the interval gets longer between the first and second dose, the GMTs get higher after that second dose. And there are also subsequent studies from this group that show that if you potentially if you extend the interval between the second dose and the booster dose, you also get higher titers there as well. So with this immunologic information, one can anticipate that that may translate as well into vaccine effectiveness. So on the next slide, this is also data from the UK, and here they did look at vaccine effectiveness. So this is vaccine effectiveness after the second dose of the Pfizer BioNTech vaccine. And on the x-axis, what you're seeing there is the interval between the first and second dose. And you're seeing it in the various age groups. So if we focus on the third column, which is the 65 to 79-year-olds, you can see that when the interval is shorter, so 19 to 29 days between the first and second dose, there your vaccine effectiveness is around 75%. But when you go out with a longer interval between the doses, so 6 weeks or more, you see the vaccine effectiveness become higher, so up to 90% and a bit lower than that. And you can see that in the various age groups as well. The one thing to note, though, is that when you have a shorter interval, it's also likely a longer period of time from your second dose to when the study is done. And that longer interval between the second dose and the time of the study can also affect your vaccine effectiveness. So those two concepts can be conflated, the interval between your second dose, between your first and second dose, and the time from your second dose to the study. So there are some studies from Canada that have helped to kind of tease those two concepts apart. So on the next slide, this is a study by Skowronski and et al., our colleagues from across Canada, who have looked at the mRNA vaccine effectiveness against infection and hospitalization by the interval. So to orient you to this slide, because I know it's pretty busy, on the left, we see data from two of our Canadian provinces. So on the left-hand side is British Columbia, and on the right-hand side is Quebec. And what you're seeing on the x-axis here is the interval between the doses. So the blue shows you the vaccine effectiveness after the second dose based on infection, and the brown shows you the vaccine effectiveness after the second dose based on hospitalization. So if we look at the Quebec as an example, you can see that when the interval is short, so 3 to 4 weeks, against infection, you're seeing a 79% vaccine effectiveness. But when the interval is longer, say 7 to 8 weeks between the first and second dose, the vaccine effectiveness after the second dose is 89%. So about a 10% difference with the longer and the shorter interval. And if you look at the hospitalizations in the brown, you can see the same thing. So with a 3 to 4 week interval, the vaccine effectiveness against hospitalization is 87%. And with the longer interval, it goes up to 97 and 98%. So with both, there's about a 10% vaccine effectiveness difference if you go from a shorter interval to a longer interval. And similarly, in British Columbia, they found similar things. The difference there wasn't quite as large, but about a 6% difference between the shorter interval and the longer interval. Now, on the next slide, what Skowronski and al. did as well is they looked at this over time. So here we're seeing Pfizer vaccine after the second dose, British Columbia on the top, Quebec on the bottom. Here on the x-axis, what you're seeing is the time since the second dose. And the different colors show you the people who've had their vaccines at different intervals. So the purple is the shorter interval between the first and second dose, versus the yellow and the green are longer intervals between the first and second dose. So if you look at the Quebec as an example, with the shorter interval, they have a lower vaccine effectiveness, and that lower vaccine effectiveness persists out over time. And that compares to the longer intervals where the vaccine effectiveness is higher, and that persists as well. So on the next slide, another example of this. This is from Kwong et al. From Ontario. And here they looked at in various parts of the outbreak, but we'll focus on the Delta wave. They're looking again at the vaccine effectiveness depending on the interval between the first and second dose. So in the red, you see people who've had a short interval, 2 to less than 5 weeks, and compared to the yellow and the blue, which are longer intervals. And you see the vaccine effectiveness as you go out over time from that second dose. And again, what you're seeing is that the vaccine effectiveness is lower if the interval is shorter and higher if the interval is longer, and that persists out over time. Not as big a difference in this study as in the previous study, but still that same, about a 5% difference that you're seeing persist out over time. So on the next slide, the summary for this portion of of our journey to the extended interval, we see that the one dose provides good protection against symptomatic disease and infection at about 60 to 70%, and that lasts out to somewhere between 8 and 10 weeks. The protection for serious infection is higher, about 80% or more, compared to protection against infection, so better protection against serious disease. And we also see that once you've gotten the second dose, the interval with the longer interval in the primary series results in a higher antibody response, and that higher antibody response also translates to somewhat higher vaccine effectiveness. So the next slide, please. So as Matthew mentioned, we've had some varying intervals over the time, but what we see here is data on fully vaccinated people out to mid-August. And what we could see as in the Canadian population on the left who have been fully vaccinated, about 52% of them ended up with an interval that was between 50 and 77 days. And very few, only 4%, had a shorter interval of 28 days or less. This varied a bit depending on our provinces and territories. Particularly notable in the territories, our 3 territories are smaller and northern, and they received a higher allocation of doses originally, so they used a shorter interval between their first and second dose, whereas the rest of our provinces that are shown here, they had a range of intervals for their population over time. So on the next slide, what we didn't expect was that there would also be a benefit from this prolonged interval based on safety. So that was not anything that we knew, and as Matthew said, that sort of emerged. So when the safety signal with regard to myocarditis and pericarditis with the mRNA vaccines was first identified, our colleagues in Ontario, as well as nationally, we began to look to see if the difference in the interval might impact the rate of myocarditis and pericarditis. So here I'm going to present a study by Buchan et al. Done in Ontario that looks at myocarditis and pericarditis rates based on vaccine product, schedule, and interval using a 7-day risk period between vaccination and the onset of myocarditis and pericarditis, and also using the Brighton collaboration levels 1 to 3. So in this study, they showed that the reported rates of myocarditis and pericarditis were higher after the second dose of an mRNA vaccine than after the first, which we've seen in a number of other studies. And this was particularly for individuals who received Moderna as their second dose. The highest reporting rate was for myocarditis and pericarditis in the males 18 to 24 years of age following Moderna as their second dose. And when we looked at that age group, the 18 to 24-year-old males, Moderna had a 5 times higher rate of myocarditis and pericarditis compared to Pfizer after the second dose. And a really interesting finding of this study was that for both vaccines, the longer interval resulted in lower myocarditis rates, whereas the shorter interval had higher myocarditis and pericarditis rates. And we'll show that a little bit more in the slide that follows. As well, the study showed that among individuals who received a heterologous schedule with Moderna as their second dose, so Pfizer as their first dose, Moderna as their second dose, the rates of myocarditis and pericarditis were higher than those who received a heterologous schedule, so who received either Pfizer or Moderna. So in conclusion, this study, in addition to showing that the age and sex risks that we know about with regard to myocarditis and pericarditis, this study also shows that vaccine product and vaccine schedule and interval may also have an impact on the rates of myocarditis and pericarditis. So as well, our National Passive Surveillance System, which is called CAPHIS, has also been looking at this data, particularly the interval data, and that CAPHIS data will contain Ontario data as well as information from our other provinces and territories. And in that CAPHIS analysis, they have also found that the interval makes a difference with regard to your myocarditis and pericarditis rates. So being shorter interval, higher rates, longer interval, lower rates of myocarditis and pericarditis. So just to explore the Buchan et al. Study just a little bit more on the next slide and to highlight some of the points that are made. So again, this is a 7-day risk period. Overall in the study, there was 297 cases of myocarditis and pericarditis. This, what we're showing here, is a sub-analysis of 202 cases from June onwards who had received 2 doses. So the data is stratified by the schedule that was received. So the first 3 bars are 2 doses of Moderna. The next 3 bars, 2 doses of Pfizer. Following that, Moderna followed by Pfizer in a heterologous schedule, and then the reverse heterologous schedule of Pfizer followed by Moderna. And within each schedule, you can see the interval between the first and second dose going from 30 days or less out to 56 days or more. So the first thing you note from this graph is the heterologous schedule, Pfizer followed by Moderna, having a higher rate of myocarditis than the other schedules. And as well, what's notable in this graph is the difference in myocarditis rates between the shorter interval and the longer interval. So for both the homologous Moderna schedule and the homologous Pfizer schedule, comparing a shorter interval of 30 days or less to a longer interval of 56 days or more, there is a 5-fold or more higher rate of myocarditis with the shorter interval compared to the longer interval. So with that, the next slide is just the concluding slide. So here what we're showing is that overall in Canada, we're seeing the same risk profile with regard to younger males after the second dose being at increased risk. We're also noting that myocarditis risk is higher after Moderna for the second dose, particularly with the heterologous schedule as well, but particularly noting that the shorter interval seems to result in a higher rate of myocarditis and pericarditis compared to a lower rate with a longer interval. And some references are provided here. And with that, I will pass it back to Matthew.
Thanks, Brenna. And on the next slide, there are just some acknowledgements of those who helped prepare the presentation. And next slide, please. Deep acknowledgements, of course, to the committee membership themselves, who have labored tirelessly over this advice over the last 2 years. And it's been quite challenging from a communications perspective at times. Whenever going off label, of course, there's always a bit of a communications challenge, and they've weathered it very well. And next slide, please. Then also the affiliated working groups. I think there are 1 or 2 more acknowledgement slides, but yeah, great. The high consequence infectious disease working group and also the vaccine safety working group under NACI, similar to the VAST working group here at ACIP. And yeah, thanks. Happy to entertain any questions at this time.
Thank you so much, Drs. Tunis and Warshawski. This presentation is now open for questions, and I just wanted to comment that I think the silver lining of this pandemic has been that it's strengthened our collaboration with international partners such as Canada and Israel and others, and it's really created a focus on what we can share and learn together to improve the health of our respective populations. So we really, appreciate you being here and sharing this information with us. Are there any questions from committee members that they would like to ask of our Canadian colleagues? Dr. Paling.
So first of all, I want to say thank you. This is really helpful, and it's wonderful to hear how the myocarditis differed. I wanted to ask if you learned anything about the resolution of myocarditis when you look at the shorter interval versus the longer interval. Thank you.
Thanks. It's a great question. So we also have my colleague Susanna Oguneki-Cook from our surveillance group at Public Health Agency of Canada. But I'll start off. To my knowledge, we have not yet been able to ascertain any differences in severity or resolution based on interval. But Susanna, I'll just turn to you to confirm if that's correct.
Thank you, Matthew. You are in fact correct. This is an area of active interest, and we are working with some external partners to put in place some outcome monitoring studies that will help us to look in more details. But the data we get within surveillance does not have that ongoing monitoring components to give us that richness of information at this time. Thank you.
Thank you. Dr. Daly?
Yeah, thanks so much for the presentation and for the collaboration, as Dr. Lee said. So do you have any sense about whether the individuals who got a shorter interval were different in any sort of systematic way from the individuals who received doses at a longer interval? Thank you.
Yeah, so that another great question. I mean, in broad strokes, as Brenna showed in one of her slides, we did see a difference in terms of our territorial populations where there was more complete allocation pushed to those territories early on that allowed shorter intervals before the sort of preference towards extended intervals was implemented. So there are some distributions across the country where we do see shorter intervals dominantly. We also have, I think, if you can flip forward to maybe one or two slides, like in the supplementals here, there's also an age-based one. Next slide, please. This also shows interval by age group, but I'll defer to Susanna also on how those have been controlled for in the myocarditis analyses. Susanna, can you comment?
Yeah, that is an interesting question, and it is a tough one, an analysis that is complicated, as you said, because as you see from this slide, the dose interval does have some like an age component to it, because that's how the vaccine rollout went. We use an age-based component to it, and we, in the surveillance data, we don't necessarily have that depth of clinical information to be able to really dig deep into the clinical presentations by age. We did see, as mentioned earlier, we did see that there, overall we had a shorter interval than the territories. However, that's such a small population, we didn't have enough cases to be able to really take a look and differentiate between what the pattern of myocarditis was for that group compared to the other populations. So we really are looking to this study that I mentioned that we're organizing to be able to really dig deeper into some of these aspects that you've asked about. Thank you.
Thank you. Dr. Sanchez.
I want to thank you as well, because really not only interesting, but really important data, and thank you for sharing it with us. I think first of all, with the availability of the vaccines and the fact that we wanted to achieve as high efficacy as possible with the 2-dose, I think that, and the studies that were done with 3 weeks and 4 weeks, I think, we certainly wanted to make sure that as much of the population and as opportune time as, in a timely fashion, that, we recommended those intervals. And certainly that may change with however the pandemic goes on. But I think it does have some important implications here. And first of all, it's really interesting with that the Moderna booster after the Pfizer was associated with more myocarditis. So, maybe that we should be, at least in the highest risk groups, the males, the younger males, that we should be maybe recommending the Pfizer, a preference to Pfizer versus Moderna. And then it also talks about pathogenesis because the longer interval was associated with higher geometric mean titers, but less myocarditis. And so maybe it's more of a, I don't know, it's maybe, the Moderna certainly is a higher dose than the Pfizer. And maybe it's not just all some immune antibody mediated process. But no, thank you for the data. I think it really may impact our ultimate recommendations because, we're trying to get that booster dose closer. Maybe that's not, the optimal thing that we should be doing. Thank you.
Thank you, Dr. Sanchez. Stinchfield.
Hello, Patsy Stinchfield, Nurse Practitioner Association. Thank you, Canadian neighbors, for this great presentation. I think about hepatitis B vaccine series and longer intervals that we worry about losing people for follow-up. Do you see any data where you're not having completion of the series as the intervals are lengthened? Any concerns about that?
That's an excellent question. I haven't seen our coverage group be able to tease that apart. Those that are receiving incomplete series, whether there was a sort of temporal association between them actually not being able to receive the second dose for a number of months, like early on in the rollout, for example, and then giving up. Is I think what you're kind of talking about. Bryna, are you aware of anything like that we've been able to tease apart in Canada?
No, I'm not aware of anything. I think it's mostly been driven by the context of the outbreak. So if the outbreak is settling down, people maybe are a bit less enthusiastic about their vaccines, but as the outbreak ramps up, they become more. So I think it may be more related to what's happening with the outbreak, but to reemphasize the importance of getting the second dose and the booster. So I don't think we've seen anything, though, that how the interval would impact that.
Can I add, this is Susanna, just that one of the things we've been very fortunate to see in Canada is we have high coverage overall. So our latest information is showing that we have almost 83% of the population that is fully vaccinated. So I think Omicron had a lot to do with that, of pushing the folks who may have, if we had any stragglers, Omicron seemed to have really created impetus for people to go and complete their schedules and then to subsequently show up for boosters.
Great, thank you.
Thank you. I'm looking for other questions. While we're waiting, I actually have one question, or one comment, one question. So to me, the data that you presented today are fairly convincing that an extended interval is not only potentially safer from a myocarditis standpoint, but also potentially more effective. And I guess the question I have for you is, do you think it is also more durable? So have you noticed in your provinces where they have had shorter vaccination intervals, whether or not the need for a booster is greater than in your areas where there are extended vaccination intervals? And the reason I ask this is because there's not only the immediate question around this series, but the potential question about the need for future boosters, and can we mitigate the need for ongoing repeated boosters, because every time there's a booster, we just it carries both benefits and risks. So the cumulative benefit risk profile over time does change.
Yeah, that's such an excellent point, and it's one that we've been very preoccupied as well. I think that like yourselves, many of us are trying to compare notes with other countries throughout the pandemic, and we've of course been closely watching what happens in Israel, understanding that Israel has been using the authorized interval. Like everything has been short and quick as things rolled out there, which I suppose has also been the case largely in the U.S. And I think there is a sense that the booster programs in Canada were actually held off a little bit longer than in other countries, and part of our understanding is that was due to the longer durability of due to those longer intervals, but it's a little bit confounded because those who got longer intervals over the summer also had a shorter time since their second dose. So if you're worrying about time since second dose, that we were at a bit of an advantage in that respect going into the fall compared to some other countries. And then that was maybe compounded by also the longer intervals affording some more durable immunity. And then there has also been some research around the breadth of response as well, that longer time between exposures, whether vaccine or actual viral exposures, in this case, could actually allow that affinity maturation to improve also the breadth of response against variants. So that's part of the rationale that we see NACI articulating in some of their statements, is the durability, higher effectiveness, and also possibly the breadth against variants that's been of interest to the committee. And we've seen not only with the primary series, but the committee continues to recommend a 6-month interval for boosters, although many jurisdictions have gone a little bit shorter on that. Brian, I'll just ask you to weigh in if you can call to mind any of the evidence that actually does speak to the longer intervals yielding better durability over time as well.
Yeah, I mean, I think we were seeing it, as you were saying, Matthew, out into the Delta period. So we were still having fairly high vaccine effectiveness in Canada as we headed into the Delta period, even against infection as well as against severe disease, because I think that our interval was longer. There were some populations where we did use a shorter interval, particularly at the beginning of our outbreak, where we were vaccinating older adults in long-term care facilities. And in that population where we saw the shorter interval being used, there was a more rapid decline in the vaccine effectiveness, whereas in the general population, we saw the sustained higher level of protection against both infection and severe disease well into that Delta period. So as Matthew said, we didn't need the booster as quickly because we were still seeing that sustained protection in our Canadian data.
The other population are healthcare workers that dominantly received a short interval, except I think in the province of Quebec, there was a longer interval used, but dominantly in Canada, healthcare workers got a short interval. And similarly, they were prioritized early on for the boosters because there was concern about that waning protection that was occurring earlier there, potentially.
Thank you. Dr. Sanchez?
Yes, thanks. Just another comment. What vaccines are you using in Canada? Are you using the AstraZeneca or any of the others, or are these are the messenger RNA ones the predominant ones? And do you have any preferential use of one versus the other, especially as it relates to the myocarditis? Have you made any recommendations based on your data?
Yeah, thanks. So it's very dominantly been an mRNA program in Canada. There was AstraZeneca that was also used in the winter, spring of 2021, but it accounts for a very small proportion. I think it's, Brenda might have the numbers at her fingertips, but it's somewhere around the 5% range was viral vector, and then the vast majority has been mRNA. Also, Janssen was recently, supply was made available to some Canadian provinces and territories in the past few months, but it's a relatively small amount. So there's been a very small amount of viral vector. The program has been over 90%, I think, mRNA, it's really dominantly an mRNA program. And Brenda, I'm going to ask you to weigh in at the end, but I'll just answer the other part as well about the preferential recommendation. So since the spring of 2021, or maybe even the winter, NACI has been preferentially recommending mRNA over viral vector vaccines. And then as the TTS or VIT emerged, that strengthened the position even further for the committee. So they, similar to ACIP, who have now also recommended preferentially mRNA over viral vectors, that position has been longstanding in Canada, so which I think was part of what pushed towards the dominantly mRNA program. And then within the mRNA category, based on the myocarditis signals that have been observed, NACI actually has preferentially recommended Pfizer over Moderna for those 12 to 29 years of age for both primary series and also for booster dose. So there is there's a preference for mRNA over viral vector And then within that age cohort of 12 to 29, there's a Pfizer preference over Moderna, in addition to the extended intervals that have been implemented. And Brianna, do you have the numbers on the program breakdown?
I don't have them right here, Matthew, but I believe you're fairly right. It's around 4% or something that were AstraZeneca. And the one thing that we do have is some mixed schedules where we had people who started with AstraZeneca and finished with an mRNA, and also, as mentioned, the mixed mRNA schedule, so heterologous. Most of the heterologous is Pfizer with the first dose and Moderna with the second dose. So we have a fair number of people, I don't know the exact number, somewhere around 12% or something like that, who have received that heterologous schedule, either heterologous AstraZeneca with an mRNA or heterologous mRNA schedules.
And I would just add, I think that one, on the theme of this question, something that's been, that we've been trying to communicate in Canada is that the strength of this surveillance system and of the research that's been able to go on has allowed us in Canada, and I think internationally in many cases, to take these very safe vaccines that are obviously authorized, and then over time we can even improve on that as we can target populations where they can even be used to make them more safe than even originally understood. So that's generally been, I think, quite a great story out of this. So through the surveillance and the research, we've been able to iterate and refine the program and actually improve the safety of already safe vaccines. So that's been a nice lesson learned in the pandemic. It can be a challenging communication message at times as things evolve, but we're quite pleased that they've been able to evolve in a positive direction to iterate on over time.
Thank you, Dr. Tunis, and thank you to your colleagues. I would love to end on that statement because we very much agree that safety is paramount to all of us, and we continue to have a focus on that to ensure that we can deliver our vaccination programs and protect the population. We will move on to the next presentation now, which is the Vaccine Safety Data Link. Our colleague, Dr. Nikki Klein from Kaiser Permanente, Northern California, who will be speaking about myocarditis after Moderna and Pfizer BioNTech COVID-19 vaccines. Dr. Klein.
All right, great. Thank you. And good afternoon. And thanks for the opportunity to talk about myocarditis and the Vaccine Safety Data Link. Next slide, please. So today, as an overview, today I'll be giving a brief review of the rapid cycle analyses monitoring COVID-19 vaccine safety conducted by the Vaccine Safety Data Link, and then really focus on myocarditis and pericarditis during the days 0 to 7 after mRNA vaccination. And here, I'll be discussing the risk after each vaccine compared to the risk among comparators who were 22 to 42 days after vaccination, and then also of direct head-to-head comparisons of the Moderna vaccine versus the Pfizer vaccine during the days 0 to 7 after vaccination. Next slide. This is a slide I think everyone here has seen numerous times, but this is the Vaccine Safety Data Link. It was established in 1990, and it's a collaboration between the CDC and 9 integrated healthcare delivery organizations shown on the map. Next slide. So you've also heard before, we're monitoring the safety in the Vaccine Safety Data Link of COVID-19 vaccines weekly using pre-specified outcomes of interest. And then we're also describing the uptake of COVID-19 vaccines over time among Vaccine Safety Data Link members. We've been doing the surveillance since December 2020. Next slide. So these are all the pre-specified outcomes that we are monitoring weekly. You can see in gray, myocarditis, pericarditis, which will be the topic of today's conversation, and I will be focusing exclusively on that. Next slide. So just a brief reminder, we initially were using the codes on the left for our early surveillance, but based on some feedback and discussions internally with the VSD investigators, we expanded our ICD code list within the past few months, and we have now expanded to include the additional ICD codes listed in red. So those, all of the data and analysis I will be showing you are based on all of these codes on the right-hand side. Next slide. So here is the vaccine uptake and primary analysis, and this is dated through January 15th, 2022. Next slide. In the VSD, administered nearly 15 million total doses of COVID-19 vaccine, and you can see that 73% of the age-eligible population is fully vaccinated. Next slide. And as you've heard before, the vast majority of vaccines that have been administered in the VSD are the mRNA vaccines. A little bit more the Pfizer, BioNTech than the Moderna, but substantial numbers of each with very few Janssen vaccines administered. Next slide. So for the analytic strategy, we compared the number of outcomes observed in the risk interval, which is 1 to 21 days after COVID-19 vaccine, were compared to the number expected. And let's just go to the next slide. So here's a slide that I think you saw earlier today, as well as a number in previous presentations as well, but I'll just briefly remind you. So this is the analytic strategy. So, and the example is myocarditis, which is what we'll be talking about today. So on each calendar day that an outcome occurred in a vaccinee, and the example is on June 3rd, we compared vaccinees in their risk interval with similar vaccinees who are in their comparison interval on days 22 to 42 after vaccination. You can see on the bottom half of the graph, the picture. And by similar, in terms of comparators, we mean that the comparators were in the same age group and at the same sex, race, and at the same VSD site on that day on June 3rd. And these analyses apply to all of the, what we call the vaccinated concurrent comparator analysis, which I'll be showing you. Next slide. So for the rest of the presentation, we'll be focusing just on a subgroup of 18 to 39-year-olds, and these are with verified myocarditis and pericarditis cases after mRNA vaccines. And again, this is data through January 15th, 2022. Next slide. So here you can see the doses that have been administered through that date in 18 to 39-year-olds by week. And you can see in red are the Pfizer doses, and in blue are the Moderna doses. And they were mostly occurred in this age group over similar time periods. Not exactly the same, but very similar, and with a similar, a little bit more Pfizer than Moderna, but robust uptake of both. Next slide. Now here, these just shows the days, the intervals between doses 1 and 2 amongst 18 to 39-year-olds. And now this is in the entire VSD population. As you can see that for Pfizer, almost all the doses were given 21 days between dose 1 and dose 2, with a little bit of variation on either side of day 21, but not much. And then similarly for Moderna, nearly all the doses were given on day 28, with some doses given a couple days later or earlier than that, but not much variation between each manufacturer. Next slide. So for our chart review summary, so for myocarditis and pericarditis, we perform chart reviews for all cases that we identify, and we've completed 297 cases through January 15th for all cases, and we still have a few that are still pending, and those are all under 18 years of age. We are chart reviewing all cases amongst 5 to 39-year-olds, and we identify the case anytime post-vaccination. So after initial chart review, they're adjudicated either by an infectious disease clinician or a cardiologist, and they confirm that the case is incident following vaccination, that they meet the CDC case definition, and those include myocarditis, pericarditis, or myopericarditis, and then evaluate the level of certainty for myocarditis. So with this adjudication, we've now verified 213 out of 297, or 71%, as myocarditis and pericarditis cases. And 79 of those have been verified amongst 18 to 39-year-olds, and those all with the onset of 0 to 7 day risk interval. And that's the risk interval that we will be, I'll be focusing on for the rest of the analyses. Based on then that 0 to 7 is based on our earlier findings of significant clustering of cases in the first week after vaccination. Next slide. So here is the vaccinated concurrent analyses results. So this is again comparing the myocarditis and pericarditis in the 0 to 7 day risk interval among 18 to 39-year-olds versus cases in the comparison interval, and this is the vaccinated concurrent comparator on the same calendar day. What you can see here is that all the adjusted rate ratios are elevated for all vaccines after both doses, or dose 1 or dose 2. But I've focused here on dose 2 after both Pfizer and Moderna. And you can see after Pfizer, We have an adjusted rate ratio of 14.3 and the excess cases 22.4. And Moderna, after dose 2, you can see a rate ratio of 18.75. It's highly statistically significant with an excess case of 31.2. And these are the same results as you saw earlier today by Dr. Shimabukuro in terms of the Moderna dose 2. Now, what this suggests is that you have indirectly, because they're not being directly compared, Pfizer and Moderna are not being directly compared here, but they're being indirectly compared. If you look at the numbers, you can see that the rate ratio after Moderna appears to be higher than after Pfizer, but that they're both very elevated. And if you actually look at the excess cases in the risk period, you can see that there's roughly do a rough comparison of 31.2 versus 22.4. But again, these are indirect calculations of indirect comparisons. Next slide. So here is just in terms of our, what is shown in the charts for our verified myocarditis and pericarditis cases 0 to 7 days after any dose. And this is after either mRNA vaccine. And this is just showing you that based on our chart review, this is cases only, that we're not seeing any obvious differences in the clinical cases from the charts between the 18 to 39-year-old Pfizer or Moderna cases of myocarditis and pericarditis. Next slide. Now, but the question is, based on the analysis that I showed you 2 slides back about the vaccinated concurrent comparators, is there a difference in the risk of myocarditis and pericarditis between the mRNA vaccines? And so as I mentioned, that the vaccinated concurrent comparators indicate that both vaccines are associated with increased risk of myocarditis and pericarditis in 18 to 39-year-olds. And that it's indirect, and that indirect concurrent comparators indirectly suggest that Moderna may be associated with more risk. So we wanted to directly test whether the risk of myocarditis and pericarditis after Moderna differs from that after Pfizer. And so we conducted head-to-head comparisons among 18 to 39-year-olds. Next slide. So this is also data through January 15th, Moderna versus Pfizer. Next slide. So here is the days between dose 1 and dose 2, only for the verified cases. For myocarditis and pericarditis in the 0 to 7 day risk interval for 18 to 39-year-olds. And what you can see here is that similar to what I showed you in the entire VSD population in this age group, that the interval between doses 1 and dose 2 was pretty consistent with what we saw in the overall population. It's centered around 21 days for Pfizer and around 28 days for Moderna. Next slide. So here you can see this is the symptom onset of verified cases in the 18 to 39-year-old Pfizer vaccine product. Now these are it's a busy slide, but if you focus on the line, the red line and the blue line, and those lines represent the rates per 1 million person days of verified cases after Pfizer in red and after Moderna in blue. What you can see is that there's a very strong clustering just visually of both of cases after both vaccines. In the first week after vaccination. And when we actually do temporal clustering scan statistics, you can see that the clustering is highly statistically significant in the first 3 to 5 days after both, after Moderna, and 0 to 2 up to 0 to 4 days after Pfizer. What you can also see is that by eye, the line of Moderna line appears to be a little bit higher than after the red line after the red line with representing the rate after Pfizer. But there's a difference, there's a distance between those 2 lines in the first week after vaccination. But to directly test that, next slide, we directly compared the intervals, and these groups were comprised of individuals who are inside the risk interval, which is days 0 to 7 post-vaccination, and the individuals were of the same age group, sex, race, ethnicity, and from the same VSD site, and on the calendar day when an mRNA vaccine had a myocarditis or pericarditis case. So here we estimated rate ratios of 95% confidence intervals, and by that is the rate post-Moderna divided by the rate post-Pfizer. And then we tested the null hypothesis that the rate of myocarditis and pericarditis after vaccination did not differ between the Moderna and Pfizer. Next slide. Now you can see that that is just shown graphically below. I won't go through this in detail, I've done it before, but you can see that on June 28th, we would take that as an example for a case of myocarditis, and we compare after Moderna vaccinations on June 28th with similar comparators as shown here on who people in their 0 to 7 risk interval after Pfizer. Next slide. So here is the updated results of myocarditis, pericarditis in the 18 to 39-year-olds in the 0 to 7-day risk interval, Moderna versus Pfizer. What you can see here is that when you, for following either dose with both sexes, we have an elevated rate ratio of 1.61 that is statistically significant and excess cases of 80 cases per 1 million doses. Now, the other analyses were trended similarly, although none of the other analyses that's shown here met statistical significance. But focusing, I think, most if you look at dose 2, I think that's probably the most relevant one of comparing Moderna versus Pfizer, which is analogous to what I showed you earlier. You see excess cases of 10.7 excess cases is not highlighted in red, but you can see that on the all doses, and 10.7 excess cases. Next slide. Now, when we do analyses of which pericarditis is excluded, again, you can see that the adjusted rate ratios all are similar in terms of the level of increased point estimates, although none of these analyses meet statistical significance. Next slide. And finally, this is a summary of myocarditis and pericarditis at day 0 to 7 after dose 2. And this is just limited to dose 2 in the 18 to 39-year-olds. And this is really just a summary of some of these analyses, which are in the earlier slides, really focusing on those dose 2 analysis. And you can see then, and now again, the analysis that includes pericarditis includes both sexes. You have an excess cases of 10.7. Although, again, none of these analyses met statistical significance. Next slide. So to summarize, among 18 to 39-year-olds, both mRNA vaccines were associated with an increased risk of myocarditis and pericarditis in the 0 to 7 days post-vaccination, particularly after dose 2. So we estimated a 22.4 excess cases per million doses after Pfizer and 31.2 excess cases per million second doses after Moderna. Among 18 to 39-year-olds, there are no noticeable clinical differences between cases after Moderna and those after Pfizer. Direct head-to-head comparisons provided evidence that the risk of myocarditis and pericarditis may be higher after Moderna than after Pfizer. And when we compare Moderna versus Pfizer, we estimated that Moderna was associated with an additional 10.7 cases of myocarditis and pericarditis per million second doses. And just a word of that, if you, that 10.7 is really, we think about it as a better adjusted excess case estimate, better adjusted than the 22.4 or 31.2 minus 22.4. That's measuring similar analyses, but these are better adjusted when you do the direct head-to-head. So both mRNA vaccines were associated with an increased risk of myocarditis and pericarditis for individuals age 18 to 39-year-olds, which I think is really what I think with the message that we really want to convey is that they're both associated with increased risk. And next slide. And again, as always, I'd really just like to acknowledge team at Northern California Kaiser Permanente, the CDC, and all the folks in the Immunization Safety Office and Marshall Clinic, and then all the VSD sites. Thank you.
Thank you, Dr. Klein. This presentation is now open for questions. I don't see any hands raised from our committee members. I'll ask if there are any liaisons who have any questions of Dr. Klein. Dr. Zimmerman?
Do we have any data from your study on the background rate differences, if any, in your populations? Over.
Well, I can, if you go to, our background rate, which is what we use for our comparison of excess cases, are derived from our population from the comparison interval. I think Dr. I'm sure Bakuro mentioned that earlier, but if you go to slide 45, I believe, this is in the background slides. Yeah, so here you can see that these are the incidence rates per person years in the risk interval and the comparison interval. And those comparison intervals are the background rates of which we're using to calculate our excess cases for our vaccinated concurrent comparator analyses. If that answers your question.
I'm sorry, I should have been clearer. For background rates from COVID disease-induced myocarditis.
Oh, I'm sorry. No, we don't have that as part of this study.
Thank you. Dr. Duchin.
Thank you. A quick question. Sorry if I missed this. I know that your primary analysis was looking at the 7-day risk window after the second dose, but you also included data on the risk window through 21 days and then showed us cases of myocarditis out past 7 weeks. And I'm wondering if those cases were also reviewed or in any way adjudicated to determine whether you think they might be vaccine associated or not.
Yeah, that's a great question. So if you go to slide 36, please. So we review all cases after vaccination of myocarditis, pericarditis, and adjudicate them. And if you look at slide, if you could go to slide 36, please. This is our primary analysis of our 21-day risk interval. So you can see here that our adjusted rate ratios, while they're not, they're numerically lower than I was showing you for the 0 to 7 day interval. What is actually quite remarkable is this, it's not highlighted in red, but actually if you look at dose 2 after both Pfizer and Moderna, you see the same excess cases for the risk interval per 1 million doses of 22.6 and 31.3. And so what that tells us is that actually all the excess risk is in the 0 to 7 day interval because it's the same as the excess cases that we see in the 0 to 7 day. But we do look at all the cases and we do confirm all the cases in both the risk interval and the comparison interval.
Thank you.
Thank you. I don't see any additional hands raised at the moment. So what I'd like to do is to move on to the next presenter. Thank you, Dr. Klein, as always, for monitoring vaccine safety on behalf of the country and also coming to present and share this data at our ACIP meeting. Ms. Danielle Mulia will be presenting on myocarditis and COVID-19 vaccine intervals, international data and policies. Please go ahead.
Thank you so much. Next slide. Today's presentation will examine international data and policies on preferential recommendations of an mRNA vaccine product or extended primary series interval as they relate to myocarditis and/or pericarditis. I will review data on the risk of myocarditis by mRNA vaccine product, focusing on the highest risk group, younger males post-second dose. Next, I will review data on an extended primary series interval, specifically how that relates to myocarditis risk and vaccine effectiveness. And finally, I will present international policies related to preferential recommendations or extended primary series intervals. Throughout this presentation, myocarditis and/or pericarditis will be generally referred to as myocarditis unless a specific study is being referenced. Next slide. Next slide. First, to contextualize this presentation, a quick refresh of U.S. findings. As we heard earlier today, in the Vaccine Adverse Event Monitoring System, or VAERS, among males ages 18 to 24 years, the observed myocarditis reporting rate within a 7-day risk interval after a second dose of Moderna was 40 per million doses. And in the Vaccine Safety Data Link, among males 18 to 39 years, the rate for myocarditis in the 7 days after a Moderna vaccine was 1.5 times the rate for the 7 days after a Pfizer vaccine. However, the adjusted rate ratio of 1.5 was not statistically significant. Next slide. Next, to review key findings from Canada we heard earlier today. In a study of passive and enhanced surveillance, the myocarditis and/or pericarditis reporting rate among males 18 to 29 years in the 7 days after a second dose of Moderna vaccine was 140 per million doses, which was almost 5 times higher than the Pfizer reporting rate of 25 per million doses. In Ontario, during the period of enhanced passive surveillance, among males 18 to 24 years, the myocarditis and or pericarditis reporting rate after a second dose of Moderna was over 5 times the Pfizer reporting rate. The reporting rates included all reports during the length of the study. Next slide. The UK's Yellow Card scheme is a national passive and active surveillance system. Among all persons ages 18 to 29 years, the myocarditis and pericarditis reporting rate after a second dose of Moderna was 71 per million doses, roughly 2.5 times higher than the Pfizer reporting rate of 24 per million doses. In a self-controlled case series of myocarditis hospitalizations in the UK, among males younger than 40 years, after a second dose of Moderna, there were 101 additional events of myocarditis per million doses compared to 12 additional events of myocarditis per million doses of Pfizer. Next slide. The Nordic collaboration, which includes Denmark, Finland, Norway, and Sweden, presented the results of their study of all 23 million residents ages 12 years and older to the Vaccine Safety Technical Advisory Work Group, or VAST, on January 10th. While these data are not publicly available, within a 7-day risk period, the rate ratio for myocarditis after either dose of Moderna vaccine versus an unvaccinated comparator was higher than Pfizer. The highest rate ratios observed were among those receiving a second dose of Moderna in a heterologous mRNA primary series. Next slide. Next, we have a retrospective cohort of all 5 million residents of Denmark, ages 12 years and older. The case definition is hospital diagnosis of myocarditis or pericarditis, increased troponin levels, and a hospital stay lasting more than 24 hours within a 28-day risk period. Analysis was done using a Cox proportional hazard model with covariates for age, sex, vaccine priority group, season, and clinical comorbidities. Next slide. Here we can see the absolute rate of myocarditis per 100,000 doses and the adjusted hazard ratio with an unvaccinated comparator for those ages 12 to 39 years and by gender after any dose. The rates were about 3-fold to 4-fold higher for those vaccinated with Moderna compared to Pfizer. In a post-hoc analysis of males ages 12 to 39 years, the rate of myocarditis was 9.4 per 100,000, or 94 per million post-dose 2 of Moderna. Using an unvaccinated comparator, the adjusted hazard ratio of myocarditis was 9.8 for Moderna and 1.5 for Pfizer. Next slide. And finally, looking to France and Germany. In both national adverse event surveillance systems, the highest reporting rates of myocarditis were among young males. In Germany, among males ages 18 to 29 years, the myocarditis and pericarditis reporting rate after any dose of Moderna was 117 per million doses, roughly 2.5 times higher than that of Pfizer. And in France, among males ages 18 to 24 years, the myocarditis reporting rate after a second dose of Moderna was 139 per million doses, roughly 3 times higher than that of Pfizer. Next slide. Here we summarize the myocarditis rate ratios comparing Moderna to Pfizer by country, subpopulation, and dose number. Looking across the studies, we can see a 1.5 to 5-fold increase in myocarditis after a second dose of Moderna vaccine compared to a second dose of Pfizer among younger males. Direct comparisons of rate ratio should be interpreted with caution due to differences in subpopulation, study design and modeling, and national setting and implementation factors. Next slide. In summary, global data suggests that the risk of myocarditis may be higher for Moderna than Pfizer vaccine. There are limitations to this review. Absolute rates are not readily comparable due to differences in case definition and risk period, subpopulation, case ascertainment, calendar time, and vaccine implementation factors, including extended primary series intervals. Finally, a limited number of geographic locations are administering both Moderna and Pfizer and had data available. Next slide. Turning now to the risk of myocarditis by primary series interval, or the time between the first and second doses. Next slide. We return to the work of Buchan and colleagues out of Ontario, examining rates of myocarditis by dosing intervals of less than 4 weeks, 5 to 7 weeks, and greater than 8 weeks among adults ages 18 years and older. Next slide. This figure shows rates per million doses among males ages 18 to 24 years by vaccine schedule and dosing interval. Across the 3 schedules of primary series, rates of myocarditis decreased as the intervals between dose 1 and dose 2 lengthened. Within each vaccine schedule, the lowest rates of myocarditis were observed among those with the longest time between dose 1 and dose 2. The highest rate was observed among persons who received Pfizer for their first dose and Moderna for their second dose within the shortest interval, 4 weeks or less between doses. Next slide. In summary, limited data suggests the rates of myocarditis may be lower with an extended interval between dose 1 and dose 2 of a primary series. These observed rates were observed both with Moderna and Pfizer vaccine. Next slide. Looking now to data on vaccine effectiveness with an extended primary series interval. Next slide. Results from this test-negative case control study from May to October 2021 among 1.2 million community-dwelling adults aged 18 years and older in British Columbia and Quebec were presented earlier today by Canada. Next slide. Here we can see adjusted vaccine effectiveness estimates against SARS-CoV-2 infection in green and hospitalization in blue by dosing interval in weeks. Results from British Columbia are shown on the left and Quebec on the right. mRNA vaccine effectiveness against SARS-CoV-2 infection and hospitalization was 5 to 10% higher with an extended interval of 7 to 8 weeks compared to a standard interval of 3 to 4 weeks. Increases in vaccine effectiveness can be observed to level off at around the 7 to 8 week interval. The overall vaccine effectiveness against hospitalization and infection for a 2-dose mRNA series with an extending dosing interval of 7 weeks or greater was 94 to 97% for hospitalization and 89 to 91% for infection. Next slide. And now turning to England. Here we have a test-negative case control study of vaccine effectiveness from October 2020 to June 2021 among adults aged 50 and older attending community testing. Next slide. In this figure, we see age group across the top and interval between dose 1 and dose 2 in weeks across the bottom. Across all age groups, starting at age 50, estimated Pfizer vaccine effectiveness against SARS-CoV-2 infection was higher with extended intervals, those greater than 6 weeks, compared to the standard 3 to 4 week interval. Next slide. Looking now at immunogenicity with an extended primary series interval. In a study by Payne and colleagues out of the UK that examined SARS-CoV-2 infection-naive persons, serological responses were higher after an extending dosing interval of 6 to 14 weeks compared to a standard interval of 3 to 4 weeks. Among persons with an extended interval, there were higher antibody and B cell responses as well as sustained B and T cell responses compared to a standard interval. An extended interval may promote efficient T cell expansion and long-term memory cell persistence. 3 additional studies found that neutralizing antibody titers were higher following an extended dosing interval of 6 to 14 weeks with an mRNA vaccine compared to a standard interval of 3 to 4 weeks. Next slide. In summary, global data suggests that an extended primary series interval may improve immunogenicity and vaccine effectiveness. Neutralizing antibody titers were higher following an extended dosing interval of 6 to 14 weeks with an mRNA vaccine compared to a standard interval of 3 to 4 weeks. Vaccine effectiveness against infection and hospitalization were higher with an extended interval of 7 to 8 weeks compared to a standard interval of 3 to 4 weeks. One limitation to note is that these studies were conducted prior to the Omicron surge, during which the absolute VE may be lower. Next slide. Turning finally to global policies. Next slide. Canada's National Advisory Committee on Immunization, or NACI, strongly recommends a complete mRNA series for all persons ages 12 years and older. Among persons ages 12 to 29 years, Pfizer is preferred for the primary series. For all mRNA primary series, the optimal interval is 8 weeks. Next slide. In the UK, there is a preferential recommendation for the use of Pfizer over Moderna in persons ages 12 to 17 years. The Joint Committee on Vaccination and Immunization has advised a minimum interval of 8 weeks between first and second doses for all persons over 18. For children and adolescents ages 12 to 17 years who are at higher risk of COVID due to underlying conditions, living accommodations, or who are contacts of immunocompromised persons, the recommended interval is 8 weeks. However, for children and adolescents that do not fall into these high-risk groups, a 12-week interval is preferred. The guidance does go on to note that in periods of high incidence or concern over a new variant, the interval can be shortened to 8 weeks. Next slide. Looking now to the Nordic countries. In Sweden, Pfizer is recommended over Moderna for persons ages 12 to 30 years. The recommended interval for both vaccines, 3 to 4 weeks. In Norway, Pfizer should be offered to persons ages 12 to 30 years. Children and adolescents ages 5 to 15 years without severe underlying conditions may receive 1 or 2 doses based on their parent's decision. Person ages 16 years and older should receive 2 doses. The recommended interval for persons ages 18 years and older is 3 to 12 weeks. For adolescents ages 16 to 18 years, the recommended interval is 8 to 12 weeks, and for children and adolescents ages 5 to 15 years with severe underlying conditions, the recommended interval is 8 to 12 weeks. However, this can be adapted down to 3 weeks based on medical assessment. Next slide. In Finland, boys and men aged 12 to 30 years are only offered Pfizer. Girls and women ages 12 and older are offered Moderna or Pfizer. The recommended interval is 6 to 12 weeks for all persons ages 5 years and older. And in Denmark, both Moderna and Pfizer vaccine are approved for persons ages 12 years and older. The primary series interval is 3 to 6 weeks, and studies have shown that the median interval between dose 1 and dose 2 is 5 weeks. Next slide. In Singapore, children and adolescents ages 18 years and younger should receive Pfizer vaccine. The recommended interval is at least 21 days. Guidance notes myocarditis risk may decrease with a longer interval, but encourages a second dose at 21 days due to Omicron. And in Taiwan, both Pfizer and Moderna vaccines are approved for persons ages 12 and older, and the recommended interval between first and second dose is at least 12 weeks. Next slide. In Australia, the recommended interval is at least 3 weeks for Pfizer or 4 weeks for Moderna, and among children ages 5 to 11 years, the recommended interval is 8 weeks. Guidance notes that the interval can be shortened in special circumstances to a minimum of 3 weeks, such as in an outbreak response, prior to the initiation of significant immunosuppression or international travel. Next slide. Finally, in France, HAS recommends persons under the age of 30 be given Pfizer over Moderna when available. The recommended interval is 6 weeks. And in Germany, the recommendation is for persons under the age of 30 to be given Pfizer over Moderna. The recommended interval is 3 to 6 weeks. Next slide. This review has a number of limitations. It was not a systematic review, and the studies presented are biased toward findings that influence national vaccine policy. Caution should be used when comparing myocarditis rates across studies as surveillance systems, case definitions and risk intervals, subpopulation age ranges, and vaccine implementation differ substantially. And finally, national vaccines policies are constantly evolving. Some policies extending the primary series interval evolved from implementation strategies to reach the most people with a first dose. Next slide. In conclusion, observational data suggests that myocarditis may be associated with receipt of Moderna mRNA vaccine in persons ages 18 to 29 years, especially in males, and shorter primary series intervals. Extended primary series intervals may improve vaccine effectiveness. And several countries have implemented policies or recommendations to lengthen the interval between doses in the primary series, which may improve vaccine effectiveness and mitigate myocarditis risk. Some have preferentially recommended use of Pfizer among males and/or persons aged 30 years or younger, which may mitigate the risk of myocarditis. Next slide. I would like to thank the team that helped pull this all together, with a very special thanks to Katie Curran, without whom this would not have come together. And now I'm happy to take any questions.
Thank you so much. This presentation is now open for questions. While we're waiting for hands to be raised, I'll just, thank you again for the comprehensive overview of the various policies. And, much of the tension over the course of the past year for us as a committee has been to try and simplify the message and actually make it more straightforward for implementation. And this, from a global perspective, I recognize how confusing this must be going from country to country, but recognizing that everyone's trying to do the right thing, which again is to optimize health and mitigate risk. Ms. Bata.
Thank you, and thank you, Ms. Mulia, for this information. Just a quick question. In the U.S. summary of findings, you've described the reporting rate after a second dose of Moderna is 42 million, but we don't have the second dose of Pfizer. Do you have that handy?
So that was pulled from the presentation earlier from our immunization safety office colleagues. I don't have the updated number from them.
Dr. Shimabukuro, are you on and want to comment on the VAERS data?
We certainly have those numbers. I just don't know if we have them accessible right now. We can get those Pfizer numbers.
Thank you.
Thank you, Dr. Sanchez.
Thank you. And it just brings up a lot of questions in my mind and issues that, as we try to refine vaccine policy and recommendations, and as you mentioned, Grace, the pursuit for safety, as well as obviously efficacy. And it seems to me that it's not just a matter of saying, Pfizer recommended over Moderna. Certainly the Pfizer has been associated from the data suggests more myocarditis. But if we really want to look at to try to even minimize the myocarditis occurrence, we're going to have to also deal with the intervals. So I think it's and trying to make a preferential recommendation, not just for the actual vaccine, but also for the interval. And I think that that this has a lot of implications. And I know we haven't talked about booster here, but it's also will have implications as well in terms of the, because it seems to me that in young males, probably, I mean, I know 29, but the risk even went up to 39, less than 40, and even slightly increased in the 40 to 49, that it's not just recommending maybe, the Pfizer dose, but it's also at a longer interval in those individuals. And certainly even among those who received the first dose of Moderna, that the subsequent dose should be Pfizer. Thank you.
Thank you. And I think Dr. Oliver will take us through additional discussion and conversation. So are there any additional questions or clarifications for this presentation that is open right now? All right, well, why don't we move...
Dr. Lee, this is Tom. I can give you those Pfizer rates now, or if
Thank you. Please
want
go ahead.
them. I'll have to talk. So as was stated, the dose, the reporting rates for Moderna in males after dose 2 in the 0 to 7 days was 40, and the corresponding 40 per million. And the corresponding rate for Pfizer was 37 per million. And then for 25 to 29-year-olds in Moderna, after dose 2, 0 to 7 days, was 18.3 per million. And then for Pfizer was 11.7 per million. And after those ages, there really isn't much of a difference between the two vaccines.
Thank you, Dr. Shimabukuro. All right, well, why don't we go ahead and move on to Dr. Sarah Oliver's presentation. She'll provide a summary and the workgroup interpretation on the topic of extended intervals for mRNA COVID-19 vaccines. Dr. Oliver.
Thanks so much, and good afternoon again. Next slide. So we went through this earlier, but the policy question for the previous ACIP vote was, should vaccination with the Moderna vaccine be recommended for persons 18 and over? Again, comparing the Moderna vaccine to no vaccine. Next slide. What we want to discuss in this presentation is an additional question for discussion that, based on new and emerging data that you've heard this afternoon, should CDC consider guidance around the interval between dose 1 and 2 for mRNA COVID-19 vaccines? And again, for this discussion, we will be discussing both Moderna and the Pfizer COVID-19 vaccines. Next slide. Then just to highlight that VAST, our safety technical committee, reviewed the most recent data from 3 U.S. safety monitoring systems, as well as data from international partners. Again, as you've heard, reported rates of myocarditis following the mRNA vaccines are higher than background, highest after dose 2 and in adolescent and young adult males. In most safety monitoring systems, the myocarditis risk is somewhat higher after the dose 2 of Moderna than dose 2 of the Pfizer vaccine. And data are limited, but emerging around the myocarditis risk following different dose 1 and dose 2 intervals. Next slide. So just summarizing what we have heard previously from the international data around myocarditis after the mRNA vaccines. Again, the risk of myocarditis was higher for Moderna than Pfizer, and again, highest after the second dose among younger males. But the rates of myocarditis were lower with an extended interval between the first and second doses of the mRNA vaccine primary series. Next slide. Then a summary of the extended primary series interval data around immunogenicity and vaccine effectiveness. An extended primary series interval may improve immunogenicity and vaccine effectiveness. That antibody responses were higher following an extended interval between the first and second doses of the mRNA vaccines compared to a standard interval. And vaccine effectiveness against infection and hospitalization were higher with an extended interval compared to a standard interval. Next slide. So now we can consider the benefit-risk balance for mRNA COVID-19 vaccines, again looking specifically in adults 18 to 39 years, but comparing vaccine-specific benefits to vaccine-specific harms with the mRNA vaccines. Next slide. The benefit-risk assessment uses the same methods as those previously described, but now includes vaccine-specific VE and myocarditis inputs for both the Moderna and Pfizer vaccines. Next slide. So these are the vaccine-specific estimates for effectiveness against COVID hospitalization from both IV and Vision. The pooled VE estimate was 92% for Moderna, which you saw earlier, and then is 87% for Pfizer. Next slide. Then this slide shows the vaccine-specific rates of myocarditis per million second doses administered among persons 18 to 39 years from VSD. And again, as you've seen before, the rates are the highest in males, 67.5 per million second doses for Moderna and 46.8 per million second doses for Pfizer. Next slide. So you've seen the setup for this before, but you can see the COVID-associated hospitalizations prevented compared with myocarditis cases expected from the vaccine, with results presented per million fully vaccinated persons aged 18 to 39 years. On the left is COVID hospitalizations prevented by Moderna in the dark red, and hospitalizations prevented by the Pfizer vaccine are in dark green. Then on the right side of the figure, expected myocarditis cases after the Moderna vaccine are in the light red, and expected myocarditis cases for Pfizer are in light green. I just want to point out one thing. So to further emphasize how the benefits far outweigh the risk, you note that on this slide and in the slides I showed in the previous ETR presentation, the scale is different on the right, so you can actually see the myocarditis cases. If we showed them on the same scale, the myocarditis bar would be so small that it would be difficult to interpret. But overall, and as we compare both vaccines, you can see that over the course of 5 months, again, the benefits of receiving either mRNA vaccine far outweigh the risk. More myocarditis cases would be expected among the Moderna COVID-19 vaccine recipients than Pfizer, but more COVID hospitalizations would be prevented among the Moderna recipients compared to Pfizer as well. Next slide. So in this slide again, you can see that it's the same setup for males aged 18 to 39 years, again for whom the myocarditis rates are the highest. The benefits still for the mRNA vaccines far outweigh the potential risk. Again, more myocarditis cases would be expected among the Moderna vaccine recipients compared to Pfizer, but again, more COVID hospitalizations would be prevented among the Moderna recipients than the Pfizer recipients. Next slide. Highlighting again the same limitations as the previous benefit-risk balance that we showed, focusing on individuals 18 to 39 years for direct benefits and risks over that 5-month period compared to vaccine versus no vaccine. And again, the assumptions don't include Omicron-specific VE estimates, assume a static hospitalization, and don't account for booster or prior infection. Next slide. So again, just summarizing the benefit risk, COVID hospitalizations averted by the Moderna COVID-19 vaccine are greater than for the Pfizer BioNTech COVID-19 vaccine. On the risk side, the myocarditis after the Moderna COVID-19 vaccine are likely greater than for the Pfizer BioNTech COVID-19 vaccine. Next slide. In summary, again, the benefits for both mRNA vaccines far outweigh the risk of myocarditis compared to no vaccine. When compared to the benefit-risk balance for Pfizer, Moderna prevents more hospitalization, however, more myocarditis cases would be expected. Next slide. So again, we've summarized several times. I'll skip to the next point, which is the rates of the myocarditis were lower with extended intervals between the first and second dose of the mRNA vaccine, and that the extended vaccine primary series may improve immunogenicity and vaccine effectiveness. Next slide. So then the question we're proposing for discussion today is, based on this new and emerging data, should CDC consider guidance around the interval between dose 1 and dose 2 for the mRNA vaccines? Before the discussion, we'll walk through a few more considerations around this possible extended interval. Next slide. So overall, if there were recommendations around an extended interval, who would it apply to? Overall, there are around 33 million unvaccinated individuals if we focus in on that 12 to 39-year-old age group. The population with no vaccine at all is lower as you get into the older age groups. Next slide. Then there are several considerations regarding extended intervals between the first and second doses of mRNA vaccines. If we think through the possible benefits, specifically for safety, we've seen that the extended interval appears to reduce the risk of myocarditis, with the lowest rates of myocarditis with an interval at least 8 weeks. Extending the interval also appears to increase the vaccine effectiveness for the primary series, although we've seen that this benefit may level out at about 8 weeks. For implementation, it is possible that uptake of the COVID-19 vaccine primary series could increase if individuals or parents desire an action that they could take that would lower their risk for myocarditis. Next slide. Then thinking through possible risk. With regards to effectiveness, there will be a longer duration of time where individuals would only have the benefit of a single dose of an mRNA vaccine. Then for implementation, for aspects that require being fully vaccinated, such as quarantine, travel, or restaurants, and extending an interval would extend the time before somebody would be considered fully vaccinated. Next slide. So overall, the work group had several thoughts around the extended interval. An individual's risk of getting COVID likely increases the longer they're only partially vaccinated with a single dose. That risk needs to be balanced with the benefits of lowering rates of myocarditis and optimizing the long-term vaccine effectiveness. This balance is influenced by the trajectory of the pandemic and recent epi of COVID-19 and can change over time. Early in the pandemic, the priority was for individuals to have optimum protection from the primary series as quickly as possible. However, guidance around COVID vaccines can be updated as new data become available, and the focus expands to also look to the future of the COVID vaccine program. Next slide. The work group emphasized that clear communication for COVID vaccines and preferred intervals is important. Being specific for what interval is desired and for whom will be critical for those and needed to implement any updated guidance. Also, there may be populations where the benefits of that earlier interval at 3 or 4 weeks would outweigh any possible risks of myocarditis. The licensed interval of 3 weeks for Pfizer or 4 weeks for Moderna would continue to be recommended, especially in circumstances where early protection is desired. Overall, after having discussions, the work group supported a preferred interval of 8 weeks between the first and second doses of an mRNA COVID-19 vaccine primary series. Next slide. Again, acknowledging our team that worked to help pull all of this together. And next slide. So questions we want to pose to ACIP is, what do you think about the possibility of an extended interval between the first and second doses of the mRNA COVID-19 vaccine primary series? And what time frame would you think that preferred interval should be? I want to highlight that we're bringing this for discussion. We'll need to continue in discussions around what would be possible or what may happen, but we wanted to make sure we got ACIP input as we consider what CDC guidance may be on this. Thanks.
Thank you, Dr. Oliver. This presentation is now open for questions. Dr. Kaling.
Okay, so thank you, Dr. Oliver, for this great conversation. And I want to appreciate everybody in the ACIP for putting together these presentations and pulling information from around the world and what we're seeing. I did find the data that was presented from Canada, from our Canadian colleagues, and from around the world, very persuasive that an extended interval, particularly in younger persons at increased risk of myocarditis, would particularly be beneficial. I also appreciated the caveats that the work group included, because it looks like, and we're all hopeful, that we're beyond the peak of Omicron, And so when the pandemic is receding, this is a particularly good time to do a prolonged interval, but that there may be cases and circumstances in which a shorter interval would be recommended. And so I did like the extended interval, and I did like 8 weeks, thinking that that looked like the ideal time according to Canadian data. So thank you.
Thank you, Dr. Paling. I'll ask if my other committee members would be willing to weigh in on these questions. It would be really helpful to the committee, well, to the ACIP and to the CDC. Thank you, Dr. Daly.
Yeah, you know, in some ways, my views are represented in some of the work group conversations that Dr. Oliver summarized. But just to jump in and say I'm in favor of extending intervals, and doing so provides benefits to the recipients of Pfizer vaccine and also provides benefits to the recipients of Moderna vaccine. And I appreciate the desire to have clear communication, and that's why I think I prefer an 8-week interval, but also to give some flexibility if somebody needs to achieve protection sooner. Over.
Thank you. Ms. Bata.
Speaking from the front line and what we're seeing in practice, in particular with the Pfizer vaccine and the 3-week interval, is that many times even 3 weeks wasn't observed, that it was much earlier. And so I think that can be a big influencer on efficacy. And so I like pushing it out, and based on other vaccine schedules that we've seen and have learned, that extended time seems to provide a better immune response. So I would be in support of the 8 weeks.
Thank you. Dr. Sanchez?
Yeah, no, thank you, Sarah. And so this is kind of what I brought up earlier. And in terms of the first question there, I do agree, and I would favor an extended interval, especially among the younger male individuals because of the association with myocarditis. And we really, I mean, this is an age group that in general does not have severe infection, but still should be protected. And so I think that trying to optimize vaccine safety in that group is extreme. Is without I mean, it's we have to optimize that. And so I definitely think that I would make a recommendation for an extended interval in that group. And I guess and clarify this a minute. So when we're looking at the extended interval, the occurrence between the Pfizer versus the Moderna, the differences seem to be less significant. And I'm asking with respect to trying to make a recommendation for one versus the other product, particularly in those who are at highest risk for myocarditis, where if it is a shorter interval, it should be the Pfizer product if it's needed, if somebody wants a quicker protection. But I certainly would favor the longer duration, the 8 weeks.
Thank you, Dr. Sanchez.
Can you comment on?
Yeah, I was going to ask, is the which point did you want clarification on?
The clarification one was the Moderna versus Pfizer one.
Yeah.
Was dealing with both with the 8-week interval.
Okay.
Yeah.
Dr. Oliver, can you respond?
Sure. Thanks, Dr. Sanchez. So I think overall, especially around that kind of clear communication, the thought was any recommendations around an extended interval would be best to be applied to both mRNA vaccines. So we wouldn't, only have an extended interval for one or the other. Then the other thing, I mean, the work group really if you look at kind of the countries that have made recommendations for a preferential for one vaccine over the other, it was around the myocarditis concerns. And ultimately, it seems like we potentially have a mitigation measure for those myocarditis concerns, which could be the extended interval. And so if you kind of look at the totality of the benefit risk, taking in VE as well as the myocarditis, it was really kind of felt that the extended interval may kind of lower that risk of myocarditis, which would hopefully negate the need for a preferential recommendation. I think certainly individual clinicians could make a choice around which vaccine they thought would be best in any specific circumstance, but as a kind of nationwide public health policy, that the extended interval would be a good way to mitigate the myocarditis risk.
Thank you. And I certainly do not imply or suggest that there should be a different interval between the two. I mean, we need to, again, harmonize it. But my understanding, if I remember correctly from the Canadian data, was that with the extended interval, the differences in myocarditis with Moderna versus Pfizer was not so significant. And maybe I might be wrong, but because if there is, then I would think that we would want a preferential product.
Thank you. Dr. Cotton.
I was curious as to the thoughts of the working group about the people to whom this would apply who are still unvaccinated, how a change in the interval might impact their desire or ability to get vaccinated, and how that might change their thoughts. And I was wondering if anybody had any comments about that. It might be something that you're not able to really fully evaluate until it happens.
Dr. Daly, would you like to respond?
Yeah, this is going to be, thanks for that question, Dr. Cotton, and I sincerely agree, and thanks, Dr. Sanchez, for your comments, because I've been thinking about those too. I mean, I think, folks that are not vaccinated today have some reluctance, for sure, and that reluctance may be across, multiple, there may be multiple reasons why they're reluctant, right? But certainly vaccine safety is one that's raised again and again. And I think, as always, these are complicated things and they're hard to communicate and it's nuanced. But I think if we're communicating, we have vaccines that are highly effective and have a high degree of safety, but we have a way to make them even safer and to reduce your risk from myocarditis. And if that's the particular reason why they're hesitant, it could encourage some additional vaccination. I think it's probably not just myocarditis, and that's not just the only issue, but it may convince some who are reluctant to vaccinate. And again, I think if the message is we already have a highly effective and highly safe vaccine or vaccines, and this is an approach to make them even safer, that might convince some folks over.
Thank you. Dr. Lair.
Thank you. You asked for my opinion, and I agree with the extended interval, and I support the 8 weeks recommendation.
Thank you, Dr. Lair. If there are other members who would also like to state their opinion, whether it's the same or different, I think that would be incredibly helpful. Dr. Sanchez?
No, I just want to add that I think the myocarditis risk is for those parents and individuals who are aware of it. I do think that it is an issue, and from a personal standpoint, it was brought up by my sister in vaccinating her children, and of course I recommend the vaccine anyway. But I do think that if we can ameliorate it, make the vaccine safer, I think that it's extremely important.
Thank you. Ms. Hayes.
Yes, thank you. Carol Hayes at the American College of Nurse Midwives. Could someone briefly remind me of the original clinical trials for the mRNA vaccines on the different schedules that they did? How many different times did they study what the frequency was between the two doses? I thought my memory is that they tried multiple different schedules. And so could anybody remind me of that?
This is Dr. Oliver. I will say that, again, as we mentioned, I think early on when we were in the kind of the middle of a pandemic, the goal was to get vaccinated, get that kind of optimum coverage, optimum protection as quickly as possible. So the early clinical trials for both mRNA vaccines had the 3 or 4 week intervals. There are actually representatives for both, so I'm happy to see if either have data on extended interval. But I think the answer is the bulk of the kind of early, phase 2, phase 3 clinical trials really did focus on that early protection. Because again, the goal was to get everybody as high a protection as quickly as possible. I don't know if,
This is Rita back from Moderna. And, I think your point is exactly right. And by and large, the participants of our vaccine trial were extremely compliant with the 4-week interval, but we do have data out to 6-week interval showing, sustain the same level of efficacy.
Thank you. Dr. Talbot, I saw your hand raised. Did you want to make a comment? I'm going to pick on you now.
Yes, just briefly. I think in many ways it's a win-win. It's not only the reduction of adverse events, but it's also the improvement in immunogenicity. And I think as we approach these new variants, the higher the antibodies and the more diverse these antibodies are, the better protected people will be. So I think it's a win-win from both safety and immunogenicity to spread out. Thank you.
Thank you, Dr. Talbot. Well, other members, if you haven't had a chance to weigh in, would really appreciate it. I'll just weigh in with my opinion now. I actually agree very much with what Dr. Talbot just said, which is that not only could this be more efficacious, but also offer an improved safety profile. I do think an extended interval between the first and second doses is an opportunity. And it's interesting because we actually have a gap right now in pediatric vaccination. So this does extend the opportunity. I would say 8 weeks, and harmonizing that would make it straightforward, hopefully to implement with a range, recognizing again that Dr. Paling mentioned that our hope, although I don't know if we're quite out of the woods yet, that with the Omicron wave just starting to recede and hopefully before another wave arrives, we'll have an opportunity to really optimize the immune response in young children. The other thing I wanted to, I'll pause there and I'll actually call on my colleague, Dr. Bell.
Thank you. Being a member of the work group, I've had the opportunity to really have a very robust discussion about this already, which Dr. Oliver, I think, reflected very accurately. And I was, very taken with the consistency of the work group members' feeling about this issue of the extended interval and the pretty much overwhelming agreement that an extended interval makes sense, as you say, for both safety and efficacy reasons. So I think I'm in support of that, and I think that at the end of the day, the picking an interval like an 8-week interval as we have, but recognizing there needs to be some flexibility is kind of the best way to thread that needle and keep things as simple as possible.
Thank you, Dr. Bell. Dr. Alt.
I think one of the potential problems is during that gap, we're going to have people who are going to get infected or be vulnerable. So we're going to have to think about that when we make clinical considerations. I was trying to go back through my copy of the slides to see if that was specifically addressed, and it looks like it was kind of tangentially addressed. If anybody on the work group can comment about that.
Dr. Daly or Dr. Oliver, would you like to comment? Dr. Daly.
So Dr. Alt, we did discuss that, and it's time at risk, but it is to be sure. But as Dr. Paling said, if this is implemented at a time frame when case counts are falling, that's a benefit. And it's still a fairly short period of time. It's a 4-week difference there or 5-week difference there. So the work group felt comfortable with the idea that you'd get some protection from a first dose, even if that second dose was delayed a little bit. But it's hard to sort of quantify that. So, and then I would like to make one point, and this is again kind of back to how we communicate this. I think how we communicate this is really important. And I think and I agree with Dr. Sanchez that when I hear parents who raise concerns about vaccine safety, they often bring up specifically the issue of myocarditis. So I think we, probably are best served by starting with that saying from Dr. Oster, which is, look, COVID is worse on your heart than vaccination, and myocarditis and any other adverse event, particularly anaphylaxis, was quite rare with the intervals we've used in the past. And then this is just an opportunity to make myocarditis even rarer with an 8-week interval. So again, I think we sort of want to emphasize those points as we communicate this over.
Thank you. Dr. Brooks.
Yes, I just want to say that the benefit of greater immunogenicity and the decrease in the rates of myocarditis make it clear to me that this is a good recommendation. The level of coverage as you go out, it looked like from the Canadian study, didn't drop off appreciably. So the concern about lowering immunity over time by only one dose is not that a major worry of mine. I think that it affords a level of safety and also demonstrates to the public that we are very focused on doing this in the right way and making these adjustments that are overall beneficial.
Thank you, Dr. Brooks. Dr. Duchin. Okay. Dr. Duchin, I see your hand is raised. I don't know if you would like to make a comment.
Sorry, I did not unmute successfully.
Okay.
I also agree with the rationale around improving vaccine safety and improving vaccine effectiveness. I think the type of graphics that were showed earlier may be very helpful in communicating to the public around any changes that may be made in the vaccine schedule. And also wondering if someone can comment on any implications for timing of booster doses if a extended primary series interval is adopted.
Dr. Oliver, I'm going to ask you if you can respond to that last part.
Thanks, Dr. Duchin. For the last point, I can say that the booster dose recommendations are based on timing since completion of the primary series. So that recommendation would stay the same, and the clock would count when you get that second dose. It would be, 5 months after that when you were fully vaccinated when you got that second dose. So that would not change.
Yeah, great clarification. Thank you.
Thank you. I did want to actually comment on 2 additional points. One is that recognizing that the current authorization either sits at 21 or 28 days, would really appreciate that flexibility in terms of whether a full recommendation is needed versus clinical guidance. This, to me, feels like a good opportunity to use clinical guidance, both from a timeliness perspective, but because we have an opportunity, again, to optimize the immune response in young children, many of whom remain unvaccinated. And our hope is that this will continue to improve vaccination rates over time. So that's just my own personal opinion, but I wanted to just recognize that there seems to be generally supportive comments in favor of an extended interval, and we'll look at understanding whether or not there's the regulatory allowance for these comments to be incorporated into clinical guidance. The other comment I wanted to just make, and I think Dr. Sanchez brought it up, was this question about Moderna versus Pfizer, and also recognizing and acknowledging the variable vaccination policies that are occurring in different countries. I do think that, I'm personally not yet sure that there is sufficient evidence to make a preferential recommendation for two reasons. One being that I do think some people decide that they would like Moderna. And in the same meeting, we've talked about people who have a suboptimal immune response. And so allowing that flexibility to be available to individual patients and clinicians to think about the benefit-risk balance for that individual, I think would be important to reflect. And that's a little bit harder, I think, with a preferential recommendation. And the second being that right now, the Moderna is authorized for, or now fully approved for 18 and older. So for those two reasons, I just wanted to offer that. I'm not exactly sure where that will head, but I want to just acknowledge the fact that there are differences in policy decisions across countries. Dr. Sanchez.
Thank you, Grace. And as much as I agree with what your statement is, that if there is a higher risk of myocarditis in the highest risk group, less than 30 years old or 39 years old, whatever, less than 40, and we have a vaccine that, given as a second dose, we have a vaccine that's associated with lower risk. I think we should have a preferential recommendation for that vaccine in that age group, and males. But I guess my question remains: with the extended interval between the first and second dose, does that difference in vaccine does it really mitigate the increased risk with the Moderna? But currently, my preference and what I would recommend somebody who received either Moderna or Pfizer as the first dose, and they're in the high risk group for myocarditis, I would say no, get the Pfizer.
Thanks, Dr. Sanchez. Appreciate that perspective. Any other comments or questions regarding these questions for ACIP? Dr. Daly.
Well, I'm just going to respond to Dr. Sanchez's comment from the work group perspective, and Dr. Lee, this is going to restate some of the things that you stated. But the ACIP COVID-19 vaccines work group, Dr. Sanchez did discuss all the issues that we're discussing today, and did feel like an extended interval was a strategy for increased safety and decreased myocarditis risk for both mRNA COVID-19 vaccines, but really didn't find that there was compelling evidence to currently have a preferential recommendation for one mRNA vaccine over another. Over.
Thank you. Dr. Freihofer.
Sandra Freihofer, American Medical Association, speaking as a practicing physician. I greatly appreciate all the data that's been presented today about ways to make the vaccines work better and make them safer, but also greatly appreciate what you mentioned, Dr. Lee, about increasing flexibility for the doctors that care for these patients to help patients make decisions. And by adding some flexibility there, physicians know what the points are that patients are concerned about, and what is the thing that might make them go ahead and get a vaccine now or wait. And the Moderna, in our previous conversations, we've heard that Moderna seem to be more durable. Now we're on the downward curve of Omicron, and the myocarditis concern is a big one. But I love in this whole conversation the concept of giving guidance, but also giving some flexibility. And I also look forward to more details in the clinical guidance about the immunocompromised patients and expanding who that group of patients is for those new booster recommendations. But thank you so much for today's discussion.
Thank you, Dr. Freihofer. Dr. Lair.
I want to point out one thing which came out in the slides, that there is a higher risk of myocarditis from Moderna, but there's also a benefit in hospitalizations. And I don't want that to get lost. And so when we talk about a preferential recommendation, I think we need to look at the whole picture. And I think the hospitalizations might be just as important as the myocarditis. Thank you.
Thank you, Dr. Lair. Okay, I don't see any additional hands raised at this moment. I'm actually going to turn it over to Dr. Oliver, and then we will move towards closing the meeting soon.
Thanks. Was just going to make a quick comment around Dr. Duchin's point, just to acknowledge that we didn't forget that he asked that question. And I think the short answer is I think none of us know if we've learned anything throughout the pandemic. It's that our crystal balls aren't always great at predicting what the future will be. But we are aware that there are studies ongoing for Omicron-specific vaccines. And as we learn what's going on with the pandemic and the pandemic evolves, as well as additional data become available, we'll review it. We'll review it in the work group, and then we'll bring it to ACIP. So we look forward to kind of discussing what may be in the future, but I don't think any of us are able to kind of predict what we think the future of these vaccines and especially with variants will end up being. But thanks.
Thank you, Dr. Oliver. Very much agree with you on that point. I see no additional hands raised, so the committee has completed its business for today. Are there any objections to adjourning today's meeting? Before we adjourn, I'm going to ask Dr. Wharton, do you have any additional comments or updates you'd like to brief the committee on before we adjourn?
Thank you, Dr. Lee. I'd like to thank the committee for sticking with us through a very long day. I appreciate all your thoughtful discussions. As Dr. Fink mentioned in his opening remarks, FDA has announced that the Vaccines and Related Biological Products Advisory Committee will be meeting on February 15th to discuss Pfizer's application for use of their vaccine in 6 months to 4-year-old children. And should that vaccine be authorized for that use, then I think we'll be meeting again. But that's for the future, and just a heads up that as things develop, we'll be in touch with the committee and sharing information as we can. So thank you.
Thank you, Dr. Wharton. And with that, I haven't seen any objections yet, so I would like to now adjourn today's ACIP meeting. Thank you, everybody, for your time and your expertise and your patience. We are all grateful for this committee's work and for the work of our CDC staff, liaisons, and ex officio members. Have a wonderful day, and I'm sure we'll be talking soon. Thank you, everyone.